Okay, come on. حلو. Let's go back. Yes. So عندكم الكواليتي اوف ذا فيلم. لازم تتاكدون هم الكواليتي of the X-ray is optimal. So the way you do that is by checking the rotation, the inspiration, and the penetration. What do these things mean? We'll see now. So we'll start with the rotation. Now, it's very important that the patient is not rotated either to the left or to the right. يعني لازم يكون البيشنت سيده parallel to the direction of the X-rays. If the patient is oriented to the left side, the clavicle or the spinous process in the middle of the vertebra, it will be closer to the right clavicle. Hello? And the opposite is also true. If the patient is rotated to the right side, the spinous process in the middle will be closer to the left clavicle. And if it's rotated to the either right or left, it will affect the findings of your X-ray. You might see things that are false or like that are not accurate representation of the X-ray of the chest. So make sure the clavicles are in the center. And then you have inspiration. So the patient needs to have a good inspiration to make sure the whole lungs can be visualized on the X-ray. Yani, if the patient is not taking a big deep breath, then you will not be able to see the lower ribs. So you will not be able to see if there's anything problematic going on in the lower zones or the lower lobes of the lungs. So you gotta make sure the patient is taking a big, nice deep breath. And to make sure the patient has taken that inspiration is by counting the ribs. You can either do it two ways. You can count the anterior ribs, as you can see here, the ones that are curved in the front. These are the anterior ones. Or you can count the posterior ribs, which are on the right side here. Okay, whichever works. So let's, for example, take the anterior ones. You can count here first rib, second rib, third rib, fourth, fifth, sixth, seven, eight. So that's good because you want approximately 6 to 7, not less than 6 or 7 ribs, anterior ribs visualized. 6 to 7. Okay, and for the posterior ribs, they need to be not less than 9 ribs. If they are less than 9 ribs, then you know the patient is not taking a deep inspiration and you cannot see the bottom of the lungs. So you can see here also 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Actually, you can see the 12th one as well. So that's a really good inspiration in this case. So that's the second thing you see for assessing the quality of the X-ray. The third thing is the penetration, which is very important as well. As you can see, the one on the left, it has basically, it's called underexposed, or there's not enough penetration of X-ray going through the chest. And so as a result, it appears very bright. Everything appears white in color. So you can't really differentiate between the high density tissues and the low density tissues. As you can see, the bone on the left side is blending in with the heart, with the diaphragm. You can't really see anything in this X-ray. The one on the right, far right as well, is not good because it is overexposed. You have a lot of radiation going through the lungs. And as a result, the lungs appear as completely black. And so the soft tissue will be basically not be visual or not be visible. You can't basically see the soft tissue in this X-ray. And you won't be able to identify if there's anything going on in the lung tissue and parenchyma. Now, the one in the middle is the one you want, which is basically called, it has optimal penetration. So it has exactly the right amount of radiation going through the lungs. So you can see in this one, you can differentiate the soft tissue, the low density tissue, from the high density tissue, which appears as bright white. The high density tissue, as you know, it is higher in density, so it is going to absorb more radiation. And so because it absorbs more radiation, it will appear brighter in the X-ray. So the bone, you can see the vertebra, it's really white, it's very bright. The heart is less dense, so it appears a bit darker. And then you have the lungs, which is even lesser dense, so it appears even darker. And that's how we identify or differentiate between different tissue in the lungs. Okay, so this is the penetration of the X-rays. So these are the three things you want to make sure you analyze before even seeing if there's anything abnormal in the chest X-ray. Okay, so as you can see, this is an X-ray of a patient. For example, if we start with the, let's say, for example, this patient is called Ahmed. His date of birth is the 27th of May, 1998. And the date of the X-ray is taken 4th of December, 2022, which is today's date, yesterday's date. So that's the first things we start with. And then we analyze the quality of the X-ray. So we start with the rotation. So if we look at the rotation of this one, hang on. So if you look at the rotation, let me actually put some annotations to make things clearer. So these are the spinous processes, yes. And this is the right clavicle of the patient, and this is the left clavicle of the patient. So you could see more or less it's in the middle. So it's not rotated to the left or to the right. So the rotation in here is good. That's what we want. Now, if you look at the what's called the penetration, the penetration is also adequately penetrated. You can see the heart. So one thing you use to make sure there's enough penetration is to see if you can see the vertebra. So the vertebra in this X-ray are visible. You can see the cervical vertebra in here. You can see the thoracic vertebra in here. So that has good penetration. So far, so good with this case. And sorry. And also, as you can see in this case, the inspiration is also sufficient, meaning that you can, if you can't, the anterior ribs. Let's use the annotation again. So this is rib number 1, number 2, 3, 4, 5, 6, 7. 7 ribs, 7 anterior ribs. So the patient has adequate inspiration taken. So you can see the lower ribs as well. So that's good. Okay. Moving on. Now, the important stuff, actually, let me erase the annotations. Now that's when you start to actually analyze the X-ray and find the abnormal findings in it. So we use a
ABCDE approach.
ABCDE approach. Thank you for that, whoever it is. And we start with the airways. So we start with the airways, make sure it's in the middle and not deviate to the right or to the left. And then we move on to breathing and see if the lung markings are extending all the way to the edges of the lungs. So for example, excuse me. Can someone see what's going on in here? Because I'm unable to find the mouse. Let me try to. يا جماعة في أحد قاعد يسمعني؟
وياك الهواجل.
اوكي حلو. لان مو قادر احرك الماوس ما ادري ليش. ما عليك. الله بالكم شوي نشوف ليش معلق هذا. Okay, let me. ما ادري ليش الماوس يختفي لما ندش السلايد شو اسمه. ثواني بس ثواني. راح يصير الشير وارد احطه مره ثانيه.
يمكن لانك كنت حاط اريزر خالد.
ولا ممكن لحظه. لا الماوس مختفية مرة واحدة يعني. أنا أجرب أشيل الشير. هم من مو راضية شو اسمه تبين ماوس. أوكي thank God. أوكي ما علي يا جماعة طولت عليكم في الشغلة هذه لأن الماوس اختفى. Okay, back to the A, B, C, D, E. So when we move on to B, which is breathing, then you need to make sure that you can visualize the lung markings. As you can see in this one, the lung markings are extending all the way to the edges of the lungs. All the way to the edges of the lungs, so you can see the lung markings clearly. And also you look at if there's any white markings or white shadow. In medical terms, we call a white shadow an opacity or opacification. So when you see any white shadows in the lungs, you say, for example, I can see some opacification in the left lung or the right lung, as we will go through them in a second. And then you move on to C, which is the heart, cardiac. And what you see in this one, you make sure that the heart is not occupying more than 50% of the lung or the cardiothoracic diameter. And also check that it is not deviated to the left or to the right side. So for example, if you see this X-ray, the heart is not more than 50% of the diameter. It's less than that. And also it's in the middle and not deviated to the right or to the left. So the heart is normal in this case. And the diaphragm, you see if you can visualize the costophrenic angles, which are these ones basically. This is the costophrenic angle, which is basically the angle between the rib cage and the diaphragm. And both, you can see them both on the left and the right side. Okay. Can you see this the slides? في أحد قاعد يشوف السلايد يا جماعة؟ واضحة السلايدات؟ نسيم.
اي واضح الحين.
واضحين اوكي تمام. نرجع بس حق اللي كنت قاعد اقوله. فمثل ما قلت لكم ال A B C D اللي هو الدايفرام زين هم make sure that there's nothing below the diaphragm, so there's no air or fluid below the diaphragm. And finally E is everything else, so you see if there's any fractures in the bones or if there's any for example wires going on around or anything else. So this is basically a normal chest X-ray. Okay, you can see the trachea in here in the middle. Okay, and you can see the left bronchus and the right main bronchus in here, and you can see the heart, and you can see the diaphragm as well in here. The costophrenic angles are visible. Okay, they're not covered, and there's no white shadows or opacities in the lungs. And this is a bit white because of the hilum. As you know, the hilum is where the blood vessels enter the lungs and also where the bronchus enters the lungs. So that's why it appears slightly white, but that's normal. You don't want white opacities in these areas of the lungs, a bit more peripheral, so a bit further from this. اوكي انزين يا جماعه الحين انا اعطيتكم السيستم اللي تبلشون فيه، فالحين ابيكم you actually apply the system and try to go through it in these x-rays. So who can volunteer to start? Who's the brave one who can volunteer to start this x-ray and analyze it? Remember, if you want to learn, you have to practice. So any volunteers? يا جماعة نبيكم تشاركون. لا أحد يتردد. اللي حاط ميوت خليه يشيل ميوت ويقول لي شنو الاكس راي هذه.
posterior anterior x-ray.
حلو سوري لحظة اخبطك شوي ما ابي. اي كمل.
روتيشن كنا شوي لليمين عدل ولا؟
يعني الروتيشن الحين لو نشوف احنا شو اسمه السباينس بروسيس اي اقرب حق الرايت كلافيكل. حلو صح كلامك. فلانها the closer to the right clavicle that means the patient is rotated to the left.
to the left.
حلو اي rotated to the left because the spinous process is closer to the شو اسمه right clavicle. حلو كمل.
inspiration ما يبين ولا عدل.
حاول تعدل شو اسمه اي تقدر الانتيريور او البوستيريور كيفك انت تشوف شنو اريح لك وحاول تعده.
inadequate inspiration يمكن ولا
adequate inspiration.
inadequate. لا.
so عندك شو اسمه عندك هني 1 2 3 4 5 6 7 8 صح. this is an adequate inspiration. حلو. afterwards
البنتريشن نقدر نشوف الفرتبرا اللي فوق بس اللي تحت لا مو حيل.
حلو.
فهذا يعتبر good penetration ولا لا؟
يعتبر inadequate penetration لان مثل ما قلت انت ما تقدر تشوف الفرتبرا اللي تحت عدل.
واذا كان البنتريشن بزياده شنو يصير؟ نشوفه عدل يعني ولا؟
اي اذا البنتريشن كان بزياده تصير الرئه كلها سوداء ما تشوف حتى شو اسمه اللانج تيشوز عرفت؟ تصير حيل سوداء. اي
هذا الاي بي سي دي ابروتش هذا عاد خليه احد ثاني.
حلو نايس تراي. يعني مهم حيل انك you go through these steps قبل لا حتى تبلش بالاي بي سي دي لانه يعني طبعا عليهم درجات وهم توري الاكزامينر ان انت يعني مو قاعد تطوف ولا شيء بالاكس راي انتربريتيشن. انزين في احد يا جماعه يبي يبلش بالاي بي سي دي اي؟ زين اذا كان البنتريشن بزياده شنو يصير؟ لحظه لان الماوس ما يفوت مره ثانيه ممكن توه. مشكله الزوم هذا. اوكي رد الماوس الحمد لله. اوكي دام انه ما حد يبي يقول اي بي سي دي راح احاول اسويها هذه. فعندكم الاي اللي هو الاير واي كاهو بالنص. حلو it's not deviated to the right or to the left, it's right in the middle. And then you have B which is the breathing or the lungs. حلو. مثل ما انتم شايفين you can see the lung markings all the way to the edges of the lungs. Okay. And you can also see some white opacification in the right lung and in the lower zone of the right lung. Hello? Because as you know, the lung is divided into different zones. You have the middle zone, upper zone, right, lower zone, and same thing with the left lung. One thing important to note is that lobes are different than zones, which means that you know, the right lung is divided into 3 lobes, as you know, and the left is into 2 lobes, left upper lobe and left lower lobe. But the right is divided into a right lower lobe, middle, and upper lobe. So if you want to stay on the safe side, it's better to talk in terms of zones. So when you talk to the examiner and tell him that there's an opacification, it's better to mention it as a opacification in the right lower zone of the lung. So make sure you use zones instead of lobes. And if you look at the heart is not enlarged. It's within, it's less than 50% of the cardiothoracic diameter. Okay, and if you look at the diaphragm, now this is a bit hard to interpret in terms of the penetration is not, as we said, it's not really good. That's why you need a good penetration, because you can see here, you can't really tell if this is from the penetration or from the consolidation or the opacification. So, but because we know it's an under-penetrated X-ray, you can see here the costophrenic angle is kind of visible, and there's no fluids below the diaphragm, and everything else seems normal. Okay. So the next X-ray, في أحد يا جماعة حاب يقول لي شنو هالإكس-راي هذه؟ يا جماعة راح أنادي بالأسامي فحاولوا تشاركون وما عليكم يعني لا تهتم إذا إجابتك صح ولا لا، بس حاول تشارك عشان تستفيد.
anterior posterior.
حلو. لحظة. اوكي. لا هذه posterior anterior لان شو اسمه، لان مثل ما انت شايف السكابيولا اللي هم العظام اللي ورا الظهر مو مغطين على الرئه، يعني انت you can see they're not overlapping the lungs from behind, so that means it's posterior anterior. وهم the heart is not occupying 50% of the diameter of the rib cage from here to here. Okay, so moving on, after that, what would you say about the rotation? هل هي بالنص، يمين او يسار؟
نص تقريبا.
بالنص. اوكي، مع ان هذه الصراحه هم مو واضحه لان البنتريشن مثل ما شايفين يعني you can't see the vertebrae. So it's a bit hard to tell, but yeah, it's sort of in the middle. Okay. Hello. And what would you say about the inspiration?
Adequate inspiration.
Adequate inspiration. Okay, good. What do you say about
penetration? مو زين.
Yeah.
It's underexposed penetration.
Hello. So you could simply say it's not adequately exposed. Or there is no adequate penetration. Alright. You don't have to say like under or over. You can just say there's no adequate penetration or adequate exposure. Hello. What about the airway?
airway.
Do you think it's in the middle?
هي شكلها سنترال مع انه ما تبين او انا ما عارف اشوفها بس.
ايه تقريبا بالنص اي يعني it doesn't look like it's on one side. And what about the breathing, which is the lungs?
lungs.
what do
شوف
you
اللنجز والله ما أعرف بالضبط شلون أطلعهم.
إيه.
هل هم الخطوط البيضاء هذه ولا اللي أنت قاعد
لا،
تأشر لنا؟
صح، في خطوط بيضاء شويه يعني اكثر من الطبيعي. حلو،
مم.
بس شنو الشيء اللي تشوفه حلو يعني obvious اللي غريب شويه بالصوره هذه؟
أحس يمين غير عن اليسار.
ليش؟
أول شيء اليمين فوق صوب الكلافيكل في شيء
حلو،
دائري.
حلو، هذه عدل.
إيه، واليمين أصلا في خطوط بيضاء أكثر.
حلو. عشان توصف هذه طريقة يعني in medical terms،
مم.
تقول حق الاكزامينر ان there is a round opacification in the right lung in the upper zone. ليش؟ لأنها بالرئة اللي على اليمين
مم.
وفوق في upper zone. عشان توصف الوايت شادو تقول لنا the opacification has well defined margins، مثل ما انت شايف أطرافها حادة يعني it is basically well defined. حلو and it's round. وهم
round classification.
white opacification or no, without saying white, it's just well defined round opacification. حلو. Opacification يعني white shadow بالmedical terms. And you can also see some white spots in here. حلو.
Mm.
Here as well. Okay. هذيل الأشياء are metastases that have spread out to the rest of the lungs. حلو. أنتم عارفين الكانسر primary cancer that can develop into secondary cancer by spreading and metastasizing to the rest of the body. So these are the secondary tumors, as you can see, which is not a good prognosis. Okay, so that's a lung cancer, yeah. And then you can see the heart. It's not huge. It's within less than 50% of the diameter of the ribcage, the thoracic cavity. You can see here the costophrenic angle. It's also not visible. There is no signs of pleural effusion. I'll come to that in a second. And the diaphragm, there's no air below it, so there's no black shadows below the diaphragm, so that's normal as well. Everything else is normal. Okay. Then this is another typical X-ray. So can someone describe this?
Sure. Is it okay? Me?
Yeah, go for it.
Yeah. Okay. In English, though, is that okay?
Yeah, absolutely fine.
We've got an AP X-ray because the scapulae can be seen well behind into the ribs behind the lungs. So AP X-ray. Don't know any of the patient details or anything like that. Guessing it's a woman. Okay. Rotation. I'm looking at both the scapula, both the clavicular, and it seems. Would you say nos, like in the middle?
Yes.
Is that what you said? Yeah. Is that okay? Okay. In terms of inspiration, I'm going to count the ribs, going 1, 2, 3, 4, 5, 6, 7, 8. Got between 8 and 9 ribs, which is fine. Going behind, so that's okay. Exposure or penetration. I can see the vertebrae very clearly, and they go behind the heart as well. So I can see the ribs the vertebrae very clearly. So that tells me it's very well penetrated, and it's not over or underexposed. It's got good exposure, this X-ray. Okay, in terms of the actual findings, airway seems central throughout, I believe. In terms of B, the actual lung tissue, it goes all the way to the edges. Yes, and there seems to be, I'd say in the bilateral upper zones, quite prominent hilar tissue, I'd say, in the top bilateral upper zones. Maybe this is normal, maybe just normal hilar tissue. I don't know. But it's got very prominent lung markings throughout
Yeah.
the whole lungs. Okay, see, in terms of cardiac, you can't assess the cardiomediastinal width or breadth because it's an AP X-ray, so I can't really assess that. Okay, and the patient has changed. Oh, okay, tamam. All seems well. The mediastinum doesn't seem to be dilated or any kinds of signs of dissection, anything like that. That's okay. Heart borders are well defined as well. D, in terms of the diaphragm, there is no pneumoperitoneum and the diaphragm seems well defined. However, I can see that there is costophrenic blunting in the right, that's the right side, the right lung, which is suggestive of effusion, perhaps, on the right side. And then E, everything else, all bones seem intact, I think. Yeah, that's it. I think so. Maybe she has left shoulder dislocation. I don't know. Her humerus seems a little bit pushed out here compared to the other side. Allah, I don't know. Maybe I'm.
You did a really good job. Really well done. You went
Shukran.
through all the steps, and yeah, and you identified the findings within this X-ray. And I really like the way you described this X-ray. You made sure you describe things and not assume or make comments. So you said that the lung markings are a bit prominent or a bit large, instead of saying, "Oh, this is, for example, maybe pleural effusion, or for example, or pulmonary edema." So you played it on the safe side, which is what you want. You want to describe things and not tell the doctor the diagnosis straight away. You can save the diagnosis when you're presenting. So that's good. Now, the prominent markings of the lungs that you mentioned, they are indeed more prominent, and that is possibly a sign of pulmonary edema, because in pulmonary edema you can see some patchy consolidation that is widespread across the lungs. So actually, can you present for me your findings? So do you know the format for how to present your findings?
Remind me what format.
So the way you present it is basically going through the whole thing like you did. So you'd start with the patient's name and then patient's date. You can make these up because we don't have the names and date. And then you can go through the rest of the stuff like you just did, the rotation.
Okay.
Yeah.
Okay.
Cool.
So we have an unidentified patient, probably female. The X-ray quality seems appropriate and examinable in terms of rotation, inspiration, penetration, exposure. So an appropriate X-ray. In terms of actual chest X-ray findings, we have a central trachea. And in terms of lung zones and markings, very prominent lung markings throughout both pulmonary tissue, which can suggest some edematous filling in both lungs. And now that my colleague here has reminded me, perhaps that it could be said that there could be kephalization of the pulmonary vessels towards the superior end, suggestive of edema below. There doesn't seem to be anything pathological in terms of like a pneumothorax or lack of lung markings at all. There is no cardiomegaly or mediastinal shift or evidence of dissection in terms of the heart. In terms of the diaphragm, it's visible and present in terms of the left side and its costophrenic angle, but the right costophrenic angle is blunted, it's not present, and it's pushed up, suggesting that there is maybe a unilateral right-sided effusion, perhaps that side. And I can't seem to find anything else on this X-ray. That's my presentation.
Well done. Good job. So just a quick note, this sign, it has a specific name, which you identified this one. It's called the meniscus sign. And it is characteristic of unilateral or bilateral pleural effusion. So you can also throw in that name if you want to impress the examiner even more, but it's good in general. Okay. Cool. Let me erase this one. Okay, you can see here in this X-ray, first of all, does anyone want to have a go at this one? It's a common X-ray finding. في أحد يا جماعة يبي يقول لي شنو بالإكس-راي؟ اوكي أول شيء نبلش well, it already says here it's AP, so we already know that, but you can also see the scapula overlapping the lungs. Okay, the heart is 50%, more than 50% of the cardiothoracic diameter. That's another thing that indicates it's AP. Moving on to the quality of the X-ray, we can see here the spinous process. It is actually deviated. Sorry, yeah, it is deviated towards the left clavicle, closer to the left clavicle a little bit. So the patient is rotated to the right side. Okay, and the inspiration, if we count the ribs, so we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, the patient has enough inspiration or adequate inspiration. Okay, if we look at the penetration, you can see the vertebra or vertebrae. So that has, I would say, good inspiration as well, although you don't see them properly at the bottom, but that's fine. Now, if we start with A, B, C, D, E, so if we start with A, you can see the trachea in the middle here, okay? And I don't know if you noticed, but that is the left main bronchus, and here's probably the right. And if you look at B, which is breathing, so you're looking at basically the lungs. So in this one, you can see the lung markings extending all the way to the edge, but you can also see some opacification, you can see some patchy opacification in here and in here, and that is a sign called bat wing sign, because it kind of looks like a bat. I'll show you in a second. And you can also see here the large blood vessels on the upper lobes, here as well, here as well, here as well. These are large, big vessels that are dilated. Now, the reason why they are dilated is because, well, first of all, the obvious thing in here, if I move on to C, you can see the heart is really big. It's more than 50% of the cardiothoracic diameter. Okay, so that's a sign of cardiomegaly, which is a big heart. That's abnormal finding. And so what happens in cardiomegaly, which is caused by congestive heart failure, is that the blood, as you know, builds up from the heart into the lungs. And that causes the blood pressure in the lung blood vessels to build up more and more and more. As a result, that high hydrostatic pressure causes the fluid to leak out of the blood vessels and into the lung tissues. Okay, so far? So as a result, because of gravity, that fluid starts to sink down the heart, down the lungs, at the bottom of the lungs, and starts to squeeze these blood vessels at the bottom of the lungs. As a result, blood will be pushed into the upper blood vessels of the upper lungs. That's why you see these big lungs, big blood vessels in the lungs on the top, and you don't see them much at the bottom. Okay, that's opacification. That's basically fluid accumulating in the lung, but these are the blood vessels. Okay, like I said, that's the large heart, and if you look at D, which is the diaphragm, you can see here the costophrenic angle is not very clear. It's blunted, as you can see here as well. It's not very clear. and that's also caused by congestive heart failure. So you can say that patient has bilateral pleural effusion, okay, and also there's a unique sign to congestive heart failure, which is basically called Curly B signs. As you can see here, there are lines, small tiny lines in here. These are called Curly B signs, which basically is when the fluid starts accumulating in the spaces within the secondary lobes of the lungs. I will explain this in another slide. Okay. Hang on. As you can see in this picture, it simplifies these findings. So patients with congestive heart failure, they have first of all, sorry, 1 second. They have a large heart, cardiomegaly. They have pleural effusion, which we just saw. They have alveolar edema, which is called as a bat wing sign. It kind of looks like a bat, if you imagine it. It's basically when the fluid builds up in the alveolar sacs, okay? And you have the dilated blood vessels on the top of the lungs, like I explained, because of the pulmonary edema, squeezing the lower blood vessels. Okay, and the curly B lines, which are a bit hard to find. It's not easy to find these curly B lines, but if you do, it really shows the examiner that you know your stuff. So try to look for them, but it's fine if you don't see them. Now, the next slide, it shows the same thing, but highlighted. You can see here, first of all, the pulmonary edema. As you can see, it's very white in here, and you can see a little bit in here as well, some patchiness. And the heart is big, more than 50% of the cardiothoracic diameter. You can see the pacemaker in here, which clearly shows that patient has a heart problem. You can also see some dilated blood vessels on the top. These big white lines on the top, these are the pulmonary blood vessels, okay? And you can see the curly B lines in here highlighted as well. You can also see them in here actually, okay? Tiny small lines at the edges of the lungs. And you can see here, you cannot see the costophrenic angle because it's filled with fluid. The pleural membrane is filled with fluid, and so it covers this black shadow. So you cannot see this angle. So these are all signs of congestive heart failure. Now, to explain to you the curly B lines, yeah, you can see this is a lung, the right lung. You can see the secondary lobules of the lung, yeah? And between these lobules, there's a small, tiny space called the interlobar septum, okay? And this space is filled with fluid from the high hydrostatic pressure that we mentioned before from the heart failure. So it starts building up into these small spaces, causing that, you know, curly B line to appear. That's why it's on the edge. It's always on the edge, and it is very narrow and it's very small. It's 1 to 2 centimeters in length. Okay. This one. Anyone willing to explain this X-ray? في أحد يبي يقول لي الإكس-راي هذه يا جماعة؟
يلا انا اسويها.
يلا.
نبلش ب A. اول قصدي anterior posterior.
حلو.
unidentified patient. الروتيشن شوي to the right. Penetration looks okay. We can see the vertebrae throughout. شنو بعد؟
عندك
lung markings. Inspiration looks 1 2 3 4 5 6. 6 was it okay ولا؟
because
7 لا so
yeah, because it's 6, you would say it's not adequately inspired. So the inspiration is not enough because you can see it's like you said, it's about 6. Let me count again: 1 2 3 4 5 6 7. 7 posterior ribs. So that's less than 9. You need to have 9 at least. So yes, low inspiration.
اي
And then ABCD.
حق A the trachea looks okay since he's rotated to the right.
Okay.
Or actually it is a little bit deviated to the right. Or for B,
Yeah.
the lung markings look fine to the edge of the lungs. There is شو اسمه air under the diaphragm for pneumoperitoneum. The aorta, the aortic arch looks prominent.
Okay.
And it's bulging a little bit. We can't comment on the size of the heart because it's an anterior posterior. For the D, like they said, the diaphragm, there's air under it.
Yep.
Everything else. Yeah, I think that's it.
Okay, well done. That's a good try. So you spotted the abnormal finding, the obvious one, which is pneumoperitoneum. So pneumoperitoneum, as you know, it's basically when air starts building in the peritoneum because of, for example, perforation in the stomach or the intestines, and starts building up below the diaphragm, and so it looks like that. And you can also comment on the blood vessels in here. You can see there's a huge dilated blood vessel in here. You can also see some prominent blood vessels in here, a bit like the one before. So you could kind of comment on these ones as well. The heart, like you said, because it's AP, it's hard to say if it's from cardiomegaly or not, but it could be actually, caused by cardiomegaly because of the dilated and prominent blood vessels. That's good. Okay. Moving on to the next one. That's another obvious pathological finding. Who would like to have a go?
Yeah, I can do this one.
Yeah, go for it.
Okay, so whenever you're starting off with an X-ray, check the patient details. Name, date of birth, hospital number, all that. It's important for OSCEs. Check the date as well. And then comment on the type, obviously here. The type is AP erect, so it's not supine. And then you go through RIPE, check the adequacy. So the rotation, you can see the spinous processes here. It's closer to the left clavicle, so it's more rotated towards the right. Inspiration, you can see around 1, 2, 3, 4, 5, 6, 7, 8, 9. You can see around 9 posterior ribs, so I'd say it's adequate. An exposure, again, you can see the spinous processes, so it's fine. Then moving on to the ABCDE approach, the airway, if you look at it from the top, it's deviated towards the left. So that's a important sign. And then looking at the lung markings on the left, the lung markings are nice and clear. Everything is normal, no consolidation or effusion. Whilst on the right side, you can see that it's more black. So that indicates some air, which indicates a pneumothorax. And because the trachea is deviated towards the left, we'd call it a tension pneumothorax. Looking at the hilum, both hilum, there doesn't seem to be any lymphadenopathy. Seems to be okay. And then for C, which is the heart, obviously you can't really comment on cardiomegaly on an AP X-ray, but it doesn't seem to be enlarged either way. It's not even 50% of the cardiothoracic ratio. Okay, so D, the costodiaphragmatic recesses on both the left side and the right side are clear. So no signs of any effusions or no air under the diaphragm as well. And then looking at everything else, bones and all that, yeah, everything's normal. We have a comment. Can you clarify the tracheal deviation? I don't think you can see my mouse, but Khalid, if you can point to it.
So
It's mild. It's not too.
that's the trachea. You can see it in here, starting from here and going slowly to this. So like you said, it is mild indeed. A bit here actually.
You won't see it at the bottom, but if you look more, more
the top.
superiorly, you can see that it comes down and then there's this shift to the left. So it's very mild. It's not one of those severe cases.
Yeah. But that is well done actually. And also something to magnify the deviation. You can see here, actually, let me show you with the mouse. You don't see clearly the right atrium in here. It's a bit hidden. So that's another sign of mediastinal deviation. As you can see here, you're supposed to see the right side of the heart. For example, if you go to this X-ray, the right apex is clear here. But if you go to this one, the right apex is not really visible in here. That's because, like Abdurrahman said, it is deviated to the left side.
There's a complete mediastinal shift.
Yes, that's right.
Yeah.
So that happens because the air builds up in the right lung, which is why you can see the right lung is compressed into a really small size, and that pressure is much higher than the left lung. So as a result, the mediastinum will be pushed to the left, as you can see in this X-ray. Okay, well done. What about this one? Anyone wants to have a go? Okay, I'll have a go at this one. So as you can see, let me go back to the previous one. So if we start with the name of the patient and the date of birth is not available, the date of the X-ray is not available as well. And looking at the quality of the X-ray, we can see the spinous process is actually in the middle. Yes. If anything, it's slightly closer to the left clavicle, slightly. So you could say it's slightly rotated to the right. Always remember, if it's to the left, then the rotation is the opposite, to the right. That's a bit tricky, so make sure you remember that. And then if you look at the penetration, you can see the vertebra, so the penetration is adequate. And then if we count the ribs, so for example, if we count the posterior ribs, starting from 1, 2, 3, 4, 5, 6, 7, 8, 9. So adequate inspiration in here. That's good. So the quality of the X-ray is good. Okay. So if we start with A, you can see this one, the trachea is in the middle, the windpipe, so it's not deviated. You can see the left main bronchus, the right main bronchus, and then moving on to B. So B, you can see the lung markings extending all the way to the edge of the lung. Okay, and then you can see some diffuse consolidation in the right lung in the lower zone. Okay, so what does that mean? Basically, that means that the consolidation or the white shadow has a diffusive pattern. Yani it's not patchy, there's no spaces in between, or it's not really well defined, it's diffused. So it's also good to use this terminology, diffuse, well defined, widespread if it's covering the whole lung. Okay, you can see here, if you also look at the heart, it is not covering more than 50% of the cardiothoracic diameter, so it is fine. You can see in the diaphragm, well, the diaphragm here, you can see the costophrenic angle, but in this one, you cannot see the costophrenic angle, it's blunted. So it's not visible. And the rest of the X-ray is fine. Now, if I want to present, yeah, I'll start with the same things, the name, date, and date of birth, and then I'll go through A, B, C, and D. So let's say I go through A, the windpipe is not deviated, it's normal, like I said. And then when I comment on the breathing, the lungs, you can see I would say obviously the opacification in the right lung in the lower zone, and you can also see there is no right costophrenic angle that is visible. And now I can safely make conclusions or make diagnosis. So I could say this looks like a consolidation that could be caused from pneumonia, and also because it's affecting the lower zone, it could be causing pleural effusion, which could be covering the costophrenic angle. And so as a result, you don't see the costophrenic angle at the bottom. Another differential, for example, could be unilateral pleural effusion. Okay. And that's when you want to say your differentials in the presentation, not when you're going through the X-ray in the beginning. Okay. What about this one? Does anyone want to have a go? Anyone want to have a go at this X-ray? I'll go through this as well. So you can see again, let's skip all the name and date of birth and jump into the quality. So so you can see the spinous process is slightly closer to the, actually it's in the middle, the spinous processes. So I would say the orientation is normal. Maybe you could say it's closer to the left side actually. So it looks like the patient has a slight right orientation, okay? And then the airway is in the, sorry, actually, let me comment on the penetration. You can see the vertebra, so the penetration is adequate. And the ribs, you can count them, and it's there's enough inspiration, so the quality is good. So you can see the airway is slightly deviated towards the left side. You can see the spinous process in the middle and the airways on the left side. Okay. And you can also, looking at B, which is the lungs, you can see some hilar opacification, which means opacification around the hilum. Okay. We can see some prominent markings around the lungs, and obviously the elephant in the room is this one. Okay, as we said, this is a meniscus sign, which means there's unilateral pleural effusion. If you see this sign, the curved smooth line covering, you know, and below it you can't see anything, it's totally white. This is basically pleural effusion, which is basically fluid building up in the pleural membrane. That's why you cannot see anything behind it, and it appears as white. So this is a very characteristic sign of pleural effusion. Okay, you cannot see the heart because of the pleural effusion again, so you can't really make any comments. And diaphragm on the right side, you can't see the costophrenic angle, so it's normal. On the left side, you cannot see it because of the unilateral pleural effusion on the left side. Sorry. Okay, everything else is normal, really. So that's basically unilateral pleural effusion. Okay.
Khalid, for the X-ray before this one, was it a PA or an AP film?
Yeah, actually, thanks for reminding me that. Let me go through it. So for that one, yeah, this is an AP because you can see here the scapula. It's covering the lungs, behind the lungs. It's overlapping the lungs, as you can see in this one, yeah. So you want to use the scapula to see if it is AP or PA. If it's overlapping the lungs, then it is AP, anterior posterior.
Okay, thank you.
No problem. Let's do the same for this one. So you can see the scapula are not overlapping the lungs in here. So this is PA. Okay. And this one, if we look at the, first of all, if you look at the rotation, you can see here the spinous process is closer to the left clavicle, so it is rotated towards the right side. Okay, you can see the top vertebra, so it I would say is adequately exposed, and hang on. And the inspiration, let's say if we count the inspiration on the left side, so count 1, 2, 3, 4, 5, 6, 7, and the 8th one. So there's not enough inspiration in this case, or not adequate inspiration. Moving on to A, the airway is actually slightly deviated, or actually it's a bit tricky because the patient is not really aligned in a normal way. So I would say it's maybe in the middle. If we move on to the breathing, we can see the lung markings only extend to the middle of the lung, or the middle of the thoracic cavity. You can see there's a huge space in here, and that basically indicates that there's pneumothorax on the right lung. Okay, so the air is building up in here and squeezing the lung. So that's the borders of the right lung. Okay. However, on the left side, it is it's normal. You can see the lung markings all the way to the edge, and there's no opacification around this region of the lung. So looking at the heart is not enlarged, meaning it's not bigger than 50% of the cardiothoracic diameter, and actually I forgot to mention something. I don't know if you noticed this thing. It is actually pretty obvious. Yeah. This is basically the blood filling the thoracic cavity, and the air is basically above it here, as you can see. So we call this hemopneumothorax. Hemo, as you know, blood, pneumo, air, thorax is thoracic cavity, yeah? So this is basically blood and air building up in the thoracic cavity, which can also happen from what's called trauma, for example. It could cause this. So this is a characteristic finding of hemopneumothorax, because the fluid level is flat. It's not curved like you see before. So it's very flat, unlike the meniscus signs, which was curved. So if you see this sign, this is most likely hemopneumothorax, yeah? And the difference between this and the pleural effusion is that the fluid in here is building up in the thoracic cavity and not in the pleural cavity or the pleural membrane. Whereas in the pleural effusion, it's building up in the pleural membrane. That's why in pleural effusion, the fluid forms a C shape or a meniscus sign. Whereas in here, it just builds up normally. Like you're, for example, putting some water in a bottle, it will be very flat. Okay. Everything else we commented as normal. You can see some circles in here. This is nothing abnormal. This is basically, not mistaken, it's either the button of the patient. He's like, probably he didn't take his shirt away. So this is basically an artifact, nothing pathological. Okay. What about this one? Anyone want to have a go? So in this X-ray, we can see, first of all, the rotation. First of all, let's start with the AP. You cannot see the scapula really overlapping. Maybe actually you see some scapula in here, yeah? Or, so it is slightly overlapping the lungs. So this would be anterior posterior X-ray, and you can see the clavicles are somewhat in the middle. So it is, the rotation is good. You can see the vertebra, so the exposure is also good. You can, if you count the ribs, 1, 2, 3, 4, 5, 6, 7, 8. So it's the inspiration is slightly less adequate, yeah. And if you look at the airways, you can see The airways is in the middle. The trachea is in the middle. The left bronchus, you can see it in here, and the right in here. If you look at the breathing, which is the lungs, you can see a lot of widespread, because it's spread all the way around the lungs, round and well-defined opacifications, multiple well-defined and round opacifications all around the lungs. And you can see the lung markings all the way to the edges, okay? And this is called coin lesion, which basically means it looks like a coin. That's why they called it coin lesion. And that is caused by, again, lung cancer metastasizing everywhere. That's why you see many coin-like lesions across the lungs. So this is, again, a very, it has a very bad prognosis. Okay. The heart is not enlarged, and the diaphragm, you can see the costophrenic angle on this left side, but not really on the right side. This could be because the tumors are covering this angle, or because there is unilateral pleural effusion, which can also be caused from lung cancer. And everything else is fine. You can see some artifacts in here, so that could be, again, another type of artifact on the patient's chest. Here, again, is a really complicated case of patient. You can try to analyze things, but because of these shadows, it will be a bit difficult. But you can, well, because the patient is clearly not in a normal situation, so they took the X-ray not in the best quality. So you can see the spinous process is a bit closer to the right. So the patient is rotated to the left side. That's the left clavicle, that's the right clavicle. And you can slightly see the vertebra. And so you could say adequate exposure. And also here you could see 1, 2, 3, 4, 5, 6, 7, 8, 9. So there's enough inspiration. So actually, that's a good quality X-ray. So if you look at the airways, it's a bit hard to look at the trachea in here, but it's slightly in the middle, so it's not deviated. Now looking at the lung markings, you can see a lot of opacification that is widespread on both lungs, and it is patchy. So you can see some patches across the whole lung. And that may be caused from consolidation, for example, may also involve some pleural effusion as well, or sorry, pulmonary edema as well. And you can also see there's some white shadows even outside of the lungs. So you can see there's a lot of white shadows in here, and that is basically a sign of surgical emphysema, which basically means when air gets trapped under the tissues of your body, like under your skin, under your muscles, it will start showing this appearance in the X-ray. So that's air trapping inside the tissues, and that's caused by surgical procedures, or like, for example, from trauma. As you can see, this patient has a lot of drains inserted in him. So this could be the reason to why he has this surgical emphysema. Okay. You can see the heart in here. It's less than 50% of the diameter of the cardiothoracic ratio, or less than 50% of the cardiothoracic diameter. You can see the costophrenic angles on here as well. And well, everything else is not really normal. So you can say there's some drains in here. You can maybe even see some ECG conductors in here. So you can comment in these things as part of your E. Okay. Now, one of the OSCE questions that come in the OSCE exam is actually I don't know. I'll ask someone to answer this, and then I'll ask the OSCE question. So anyone wants to have a go at this? I would suggest you actually try to have a go because that might come in the exam. في أحد يبي يشارك؟ Okay, مو مشكلة. So this patient, well, first of all, if we start with the rotation, you can see the spinous process is in the middle. Actually, it's slightly rotated to the left. I mean, the spinous process is close to the left side. Is it, or maybe it's slightly closer to the left club, so it is slightly rotated to the right side, and the penetration is adequate. Inspiration is adequate as well. Is it? Let me double check. 1, 2, 3, 4, 5, 6, 7, 8, 9. Yes. So that's a good quality X-ray. So if you look at the airway, it looks like it's slightly deviated to the right side, yeah? And that's the left bronchus, the right bronchus. So it's slightly deviated to the right. And you can see the breathing, the lung markings appear slightly prominent in here. And you can see some slight opacification in the upper zone of the left lung. Now, that is not really well defined in border, but it does look round in shape. So that is basically caused by a lung cancer, and it is a Pancoast lung tumor because it's on the apex, sitting on the top of the lung. Okay, so Pancoast tumor is a lung that is sitting on the apex of the lung or on the top of the lung. And you can see the heart is within half of the cardiothoracic space. The costophrenic angles are visible. Everything else looks normal. Okay. So they like to ask what type of tumor this is. Like I said, it is a Pancoast lung tumor. And also they will ask what type of lung cancer this is. Now, if you want to get excellent in your OSCE, which I'm sure everyone would want that, you have to make sure you answer this correctly. If you go through the A, B, C, D, E, the quality, the date, literally everything else, and not tell them what type of lung cancer it is, you will not get excellent. Basically, you need to get excellent. You need to tell them the type of lung cancer that is. Anyone wants to have a go? Anyone that wants to have an excellent on their X-ray OSCE? I feel like I'm putting a lot of pressure on you guys. I'm just joking here. So this is a non-small cell lung cancer. Okay. You have two types of lung cancers. You have small cell lung cancer and you have non-small cell lung cancer. The Pancoast tumors are usually non-small cell lung cancer, and they can sometimes ask you what investigations you want to do to identify that type of cancer. So if you know your stuff, you know this is a Pancoast tumor, you know this is non-small cell lung cancer, you will know that non-small cell lung cancers cause syndrome of inappropriate ADHD, or like in short SIADH, which basically causes your body to retain the fluid because it reduces your urination and causes the kidneys to retain that salt and that water. So as a result, the patient will start having a lot of fluid retention. So you want to test for that protein in your blood. So that's one question you could have. Another question is this X-ray.
Khalid,
Yeah.
This question on the previous slide. Are all lung cancers classified either non-small cell lung cancer or non-small cell lung cancer ولا لا؟
Yes, you could. They are divided into these two main categories: non-small cell lung cancer or small cell lung cancer. However, that's a good question, by the way, because non-small cell lung cancer can be divided into further divisions. Okay. One of them could be large cell cancers, lung cancers, and other types of subdivisions. So you could have more than one type of non-small cell lung cancer, but in the exam, they only expect you to differentiate the lungs into either, sorry, the tumors into either non-small cell or small cell. You don't,
And sorry.
yeah,
Go on.
yeah. So you don't need to tell them what type of non-small cell lung cancer it is in the exam, because you can't really tell them. You need to do tests and investigations, histology, and things like that.
Okay, and from the chest X-ray, how did you know that this is a non-small cell lung cancer?
Yeah, good question. So you can see the tumor, it's on the top of the lung. Look, it's sitting on the top of the lung. And because it's sitting on the top of the lung, we call it Pancoast tumor. Okay. And most Pancoast tumors are non-small cell lung cancers. That's why it's very important إنك تعرف إذا الtumor فوق on the top of the lung, or if it's in the middle of the lung or next to the hilum. Okay, it will be clearer with the next example, because the next example is basically shows a normal lung tumor. It's not on the top of the lung, as you can see. It's actually in the middle or the bottom of the lung, and it's pretty huge. It is a well-defined consolidation that is round, and it's sitting in the middle zone of the right lung. Always go for zones if you're not sure which lobe it is. It's much easier. Okay, and so yeah, again, they can ask you what investigations you want to request, what type of lung cancer this is. Okay, so in contrast to the previous one, this one is small cell lung cancer. Okay, why? Because most small cell lung cancers are close to the bronchioles. Small cell lung cancers usually form within the main bronchus. So usually it's sitting in this area, or on this area if it's on the left side. So that's how you could tell if it's small cell lung cancer. Yeah, as long as it's not on the top, it's most likely to be a small cell lung cancer. And so the investigations you would want are PTH, RP, which is basically parathyroid related protein, and ACTH levels as well. So what does that mean? That basically means is that the small cell lung cancer, some of them, they can release a protein that is similar to PTH, which is basically parathyroid hormone. As you know, parathyroid hormone, it causes your calcium levels to go up. So people with these small cell lung cancers may have hypercalcemia. Another hormone they release is adrenocorticotropic hormone, which causes Cushing syndrome, as you know as well. So that's why you request these things as part of your investigation. Because if they are positive, or if you have high levels of these things, then it's likely that it is caused by a small cell lung cancer. حلو. طبعا عشان to not confuse the two between each other, try to remember that small cell lung cancer releases or causes hypercalcemia and Cushing syndrome, whereas the previous non-small cell lung cancer causes SIADH, which is basically it releases protein similar to ADH, antidiuretic hormone. As you know, antidiuretic hormone, from the name, stops you from urinating. antidiuretic, so it causes water retention. So this is the difference between non-small cell and small cell lung cancer. So that's why you need to make sure if it's in the top of the lung or the middle of the lung or anywhere else other than the top. Okay, so that's chest X-ray. So moving on to abdominal X-ray, yeah? It's slightly different abdominal X-ray to analyze them. We use another system, but it's a bit simpler and smaller than the chest X-rays. So we start with B. We use a system called BBC. So B stands for bowels and everything else. Second B stands for bones. Third one stands for calcification and artifacts. Okay. First thing we look at the bowels. Obviously, that's the main thing we want to check on and interpret. And then the bones around the bowels. And then if there's any calcifications like kidney stones or gallbladder stones, things like that. And artifacts like you will see in a second, like for example, someone's hair or something piercing or jewelry, anything like that. So that's a normal abdominal X-ray. Okay, you can see the white arrows are pointing towards the large colon or the large bowel, whereas the black arrows pointing towards the small colon. Okay, the small colon is, as you know, sitting in the middle, whereas the large colon is surrounding it. So you can see this is the ascending colon, transverse, and descending colon. And you can't really see the rectum or the sigmoid colon in here. Sometimes you can see it, sometimes you don't. Okay. And yeah, as you can see, the small bowel is clearly smaller than the large bowel. And also you can see the folds, the rostra, or the folds of the large bowel. You can see the folds don't extend all the way to the end of the, all the way across the lumen. Let me show you through a different slide. So this is a zoomed in picture of the small bowel, yeah? So you can see the folds, first of all, they cross all the way across all the lumen. Okay, they extend all the way across the lumen. And there's many of them. Okay, there's a lot of them. So these are two characteristics you can use to differentiate between the large and the small colon. And obviously the small colon is usually not bigger than 3 centimeters in diameter, whereas the large colon is not bigger than 6 centimeters in diameter. Okay, and the cecum, as you know, is the first part of the large colon. It is not bigger than 9. So remember 3, 6, 9. 3 for the small intestine, 6 for the large, and 9 for the cecum. Okay. This is the zoomed in picture of the large intestine. Okay. You can see that the folds are less frequent. There's not much of them compared to the previous one. And the folds don't extend all the way across the lumen. They only extend part of the lumen. Okay. So we went through the bowels. Now we will look at everything else. We're still in the first B, yeah? So we're looking at everything else like the kidneys. You can see the inferior part of the left kidney, okay? And you need to focus to make sure you spot these things as they are very subtle. And also depends on the quality of the X-ray. You also can see the inferior edge of the liver in here. That's the psoas muscle, as you can see. And these are obviously the pelvic bones, the vertebra, coccyx, and sorry, that's the sacrum. You can see the rest of it. And that's the large intestine. You can see some food inside of it in here, which is why it appears white. So yeah, you can see the large intestines in here clearly. So again, we're going to practice in these ones. So that gives away the answer, unfortunately, I think. So you can see in this X-ray the bowels, they form many loops around each other. This is actually the small intestine. Why? Because you can see there are many folds in here. Okay, and it's in the middle, and it has a unique shape or pattern. It looks like a compressed spring or coiled spring that is wrapped around itself, as you can see. So that's a sign of small bowel obstruction. Okay. Usually it's caused by adhesion. 75% is from adhesions, 10% is from hernias, and the rest are usually caused from neoplastic compressions, meaning cancer compressing the small intestines. So these are the main causes of small bowel obstruction. Okay. Now, looking at this photo or this X-ray, you can see this obvious huge sign, and this is basically called the coffee bean sign. Okay, because it obviously looks like a coffee bean. Okay, and this is caused. First of all, anyone wants to have a go at this? What do you think this is, or what caused this? شنو تتوقعون سبب هالشيء هذا؟
Sigmoid volvulus.
Yeah, I don't know if you guys heard it. This is a sigmoid volvulus. That's right. This is because the sigmoid it twists over itself, and as a result, it gets occluded. And so as a result, things start to build inside of it, causing it to be really large in this way. And obviously this is dangerous as it could cause perforation, it can cause necrosis of the sigmoid, and it could be fatal if it's not managed urgently. So this is called a sigmoid volvulus. Okay. What about this one? So that one, go on. That one is, again, it's also a volvulus, but it's a cecal volvulus, or volvulus, sorry, not a sigmoid volvulus, because you can have a volvulus in the cecum, as you know, the final part of the colon, or the beginning of the colon, the cecum. But usually it happens in the sigmoid. And the cecal volvulus, it has a baby, they call it as a baby sign because it kind of looks like a baby inside in here. So again, you can use these signs to help you spot these diagnoses. Okay, if you look at everything else, you can't really see the bowels here clearly. Maybe this is this looks like the descending colon or the transverse colon. Actually, this is the descending colon. So it's not very clear in this picture, but you can see that sign in here. Okay, so these are the types of large bowel obstruction. You can have small bowel obstruction, or you can have large bowel obstruction. And so causes of large bowel obstruction, as you've seen, sigmoid volvulus, cecal volvulus, and tumors or cancers. Okay, now again, this is another characteristic pathology. Anyone wants to have a go? This one? Okay, so you can see some features in this abdominal X-ray. First of all, you can see the ascending colon. It looks like thumbprints, basically. If you think of it this way, it basically look like thumbprints, and this is called thumbprinting. And you can see across in here, the transverse colon is dilated and it lost all its folds. You can't see any of the folds in here anymore. That's because the muscles are completely relaxed in here. The tinea coli, as you know, they're completely relaxed, causing the hostra to disappear. I'll come to that in a second. And you can see here the pipe appearance, because it looks like a pipe. That's because it also lost its folds, or the hostra. Now, this is usually caused by IBD. So it could be caused from either Crohn's disease or ulcerative colitis. The reason why you can see thumbprinting in here, that's because there's inflammation in IBD within the colon, as you know. And this inflammation, it causes swelling within the hostra or within the folds, causing these folds to swell and form this pattern of appearance. Okay, and then the reason why you have this large colon, this is actually called toxic megacolon because it's large, mega, and the reason why it's toxic because inflammatory markers will start to enter the bloodstream and cause systemic inflammation. It will be toxic to, you know, the whole body systems, causing general inflammation within the body, which is also something that needs to be treated urgently. So the reason why the tinea coli muscles relax is because of the inflammation causing the colon muscles to relax. And as you know, the tinea coli, they are perpendicular to the hostra, if you can imagine it. I don't know if I have a picture, but they are very perpendicular to the hostra. So when they contract, they will pull the colon towards itself and cause these folds to happen. That's why you have the hostra, because of the tinea coli muscles contracting. So when these tinea coli muscles relax, you will have a much more dilated and much more featureless and smooth colon that looks like completely like a pipe or very straight and no folds at all. So that's why you have these features in IBD. Okay, you don't always find them all together. You may just find some thumbprinting, or you may find just the lead pipe. So it's very important to keep an eye on that as well. And here you can see there is multiple fluid levels on this abdominal X-ray. Now, this is caused from small bowel obstruction, causing the fluid levels to be in completely different levels, and usually it's supposed to be less than five different fluid levels. So if you see more than 5 different fluid levels, then it's probably caused from bowel obstruction, either large or small. If you have any questions, feel free to ask me or let me know. You can't really see the large or small colons in here, but it's very important to keep an eye on this characteristic finding, as it could indicate obstruction. So we're almost done, by the way. This is almost the final part of the slides. So it's very important to be able to distinguish between different shades of white, because as you know, different densities of tissue absorb different amounts of radiation, and that causes the tissue to appear in either very bright or very dark. The higher the density, the more absorption, the brighter it will appear. That's why the bone appears brighter, and then the soft tissue like the muscles, as you can see, appearing less bright, and then the air, which is completely low density, appearing dark or black. So now you'll see why that is important. As we know, we finished from the first B, now the second B, bones. Yeah. After going through the intestines and the colons, you will have to look at the bones quickly. Obviously, the most important thing is the first B, to make sure the bowels and the visceral organs are normal. After you do that, you look at the bones. You can see this bone is clearly not normal. That's because you can see many white spots on it. Okay, across the pelvic bone, across the femur as well, and that is caused by metastatic bone cancer that has spread all across the bone, and these are called sclerotic lesions. That's because the bone is, or the tumor that is attacking the bones, is causing sclerosis. As a result, the bone becomes denser and it appears brighter and whiter. So that's why you have some white spots. This is basically the cancer attacking these regions and causing it to be more dense. Here as well, you can see some dark spots across the pelvic bone. And this is caused again by bone cancer, but this time the bone is actually eating the bone away. And this is called lytic bone lesions or lytic metastasis. As you know, lysis is breakdown. That's why they're called lytic. So as you can see, this is an obvious sign of bone cancer. The rest of the bones kind of appear normal, so you can see the sacrum here is normal. This is probably the bladder. You can see some space inside of it in here. So yeah, everything else is normal. Now, who would want to have a go at this? What do you think that is? There you go. Okay, so
It's a renal calculus.
that's right. On the left side, yeah?
Yeah.
Yep. And you can see it's clearly very bright. That's because it's a kidney stone. We call it kidney calculus. Hang on. So it appears very white because, as you know, kidney stones are very dense. They're very similar to the bone, so they appear very bright. And that's why they appear in that shade of white. If you look everywhere else, you can obviously see the psoas muscle in here. You can see some of the large intestine in here as well. And you can also see the inferior pole of the kidney, or left kidney. Obviously need to pay close attention to that. And the bones are clearly visible in here and normal. Yeah, so this is a renal calculi or renal calculus because it's one. What about this one? So this one is again.
It's bilateral staghorn calculi.
That's right. Yeah, it's called staghorn calculi because it looks like a seahorse. Staghorn is basically means a seahorse, and it does look like a seahorse. And this is basically when a huge kidney stone that occupies the whole kidney forms. That's why it looks in this way, because it's basically filling the whole kidney. You have it in both sides, so it's bilateral. Yeah, and this is the ascending colon. Yeah, you can see some space inside of it. Again, the psoas muscles in here. So yeah, this is bilateral staghorn calculi. What about this one? I'll be really impressed if someone can identify this abnormality. It's not an abnormality, actually. Anyone wants to have a go? Okay. So we moved on from B, which is bones, and then we finished we've moved on from the first B, which is bowels, second B, which is bones, and then the third, which is C, which is calcification or artifacts. So we've seen some calcification like kidney stones, staghorn. You can also find some stones in the gallbladder on the right upper side of the abdomen. But this one is basically tummy piercing. It's nothing abnormal, no stones in here, nothing worrying. It's just a tummy piercing, and it appears in that way. So it's always important to keep in mind some artifacts are probably going to be there in the X-ray. So not everything you see is an abnormality or pathological finding. You can have some jewelries, people some forget things on them, or piercings or any other things. Okay. And we are done. So thank you everyone who attended. I hope that was really useful. I tried to make it useful for everyone that's attended. If you have any questions about whatever I just said, mention it to me directly or any one of our KIMSA team. You can email me your questions or like whatever you want to ask. I'm available for whoever needs it. So yeah, feel free to ask me questions. And good luck with your exams and your OSCEs. I'm sure you'll do well if you like make sure you revise these things I've just mentioned. So yeah, good luck.
يعطيك العافية الهواشي.
الله يعافيك. مشكورين يا جماعة.
يعطيك العافية.
الويكند معكم الحين.